Good afternoon, everybody, and welcome you all to the CGR combined ground round from Department of Hematology. So we had one ground round in 2017 where we have presented our data on DVT. So this time I decided to have a CGR on cancer-associated thrombosis. If you see the cancer, if you see our data, we have a DVT clinic on Thursday every day. So most of the patients refer to hematology clinic for DVT managements. The last CGR we have presented DVT our data on CG on the general DVT. So we usually see around 150 to 250 new patients per year. And after that, if you see the last more than around 3,500 patients, DVT patients on follow-up in our hemostatic clinic. In last 5 years, around more than 1,000 patients under follow. So if you see the secondary conditions, most of the times you see there is no actual secondary causes of DVTs, but one of the most important cause of secondary cause is malignancy or cancer-associated thrombosis. We have few publications on cancer-related thrombosis, and we have recently have a data of one of our thesis on cancer-related thrombosis. So I would like to have a general overview of cancer-related thrombosis in next 45 minutes. And there is also significant improvement in DVT management, especially newer anticoagulant, oral anticoagulants, and heparin drugs. So this is the outline of our presentation. So we'll start with pathophysiology and etiology of cancer-related, subsequently risk for cancer-associated thrombosis, and subsequently we have a department data, especially pattern of comparison from the previous presentations, prophylaxis and treatment, complications and quality of life, and finally our summary and future directions. So to start with pathophysiology and etiology of cancer-related thrombosis, I would like to invite Dr. Pathisa. Dr. Pathisa, please.
Good evening, everyone. Today we'll start with pathophysiology and etiology of cancer-associated thrombosis as a part of CGR. So, thrombotic complications in cancer can vary from venous thromboembolism to disseminated intravascular coagulation, as well as some cases of arterial thromboembolism. Armand Trochu first described the association of thrombosis with cancer in 1865, and mechanisms that promote the thromboembolic events are multifaceted. 4 to 20% of cancer patients will experience VTE at some stage, the rate being highest during the initial 6 months. So, and the mortality caused by VTS is the second leading cause of mortality in cancer patient, second to cancer itself. So, whenever the VTE is associated with cancer, it is associated with more mortality than without VTE. And also here in the graph, this is a study by Corona et al., where over the decades, whenever the VTE is present in cancer patient, the percentage of mortality is more. And also over the decades, the incidence of VTE is also increased over the decades in different studies, for suppose by Corona et al. In a study in US hospitals, and also in the Danish study, the below graph is by a Danish study. So the increase in the incidence of VT is attributed to increased imaging technologies which can detect the thrombosis. Also, the overall survival of the chemotherapy cancer patients has increased. And also, some of the novel agents used in the cancer therapy will cause more thrombosis than the conventional chemotherapy. And this increase in the trend is consistent in all types of cancers. To start with the risk factors which are associated with the thromboembolism in cancer patients, they are cancer-related, patient-related, or treatment-related. Cancer-related risk factors include active cancer itself, advanced stages of cancer, and metastatic cancers. And also certain types of cancer are at higher risk of development of thrombus formation, like pancreatic cancer and gastric cancers and brain tumors, and whereas the incidence is least reported in breast, prostate, and head and neck cancers. Though different studies showed different incidence of VT and different types of cancer, pancreatic cancer has been associated and with thrombosis and been reported consistently in all the studies. In patient-related risk factors, patients older than 65 years are at more risk, and some modifiable risk factors are common for cancer and non-cancer patients to prone for thrombosis, that is obesity, smoking, and activity level. And most important factor to be considered is a history of the prior VTE, which will increase the risk of thrombosis in the cancer patients. And other risk factors include familial and acquired hypercoagulability, including pregnancy, medical comorbidities, hospitalization, prolonged immobilization, and poor performance status. Treatment-related risk factors include major surgeries, central venous catheters, chemotherapies, and certain chemotherapies like cisplatin, L-asparagines, lenalidomide are associated with increased incidence of thrombosis. And in comparison with the conventional chemotherapy, some of the novel agents like protein kinase inhibitors, immunotherapies, and exogenous hormonal therapies and anti-angiogenic agents have increased incidence of thrombosis compared to the conventional chemotherapy. So to know the overview of the mechanisms of thrombosis in brief, Virtuous triad is a well-known eponymous triad which consists of three broad categories of factors which will lead to the thrombus formation. This includes stasis of blood, endothelial injury, and hypercoagulability. In cancer patients, there is frequent immobilization and surgeries which will lead to stasis of blood flow, and also the blood vessels are often compressed by the tumor masses, increasing the stasis of blood flow. Endothelial injury is caused by tumor cells directly invading the endothelial cells, and also the cytokines released by these cells will cause procoagulant phenotype of the endothelial cells. And the hypercoagulability of the triad is because of the hyperleukocytosis, thrombocytosis, elevated hematocrit, especially in MPNs, increased tissue factor release, and reduction in tissue factor plasminogen inhibitor. So these mechanisms are driven either by direct factors or indirect factors. Direct factors are several factors expressed or released by tumor cells themselves, whereas indirect factors are the factors released from the cells in the host environment, which include platelets, endothelial cells, macrophages, and neutrophils. To talk briefly about the direct mechanisms, tumor cells on their cell membrane produce tissue factor, express tissue factor, which is a key initiator of the coagulation cascade. Along with that, there is an expression of cancer procoagulant, which is a serine protease, which will activate directly factor 10 to 10A, and also odopenin expression, which will activate the platelets through CLEC2 receptors. There is a secretion of tumor microparticles or extracellular vesicles. These are nothing but membrane-bound tiny particles without DNA, and these membranes also have the same factors as the tumor factors because it is formed by the same cell membrane. During the formation, phosphatidylserine of the inner membrane is also exposed on the outer membrane in these microparticles, which acts as a procoagulant. And also, tumor cells produce direct platelet activators like ADP and thrombin. By these mechanisms, it increases the coagulation activity, and also tumor cells produce increased plasminogen inhibitor, which in further inhibits the fibrinolysis, and further that inhibits the clot dissolution, thus anticoagulation is reduced. And then talking about the indirect mechanisms that promote cancer include cancer cell dissemination and intravasation to nearby blood vessels. This will lead to endothelial damage, and inflammatory cytokines which are released will activate platelets and promote the procoagulation. Cancer-derived factors also induce a neutrophil extracellular traps. What are these NETs? NETs are DNA-associated mesh of histones and a neutrophil-derived proteases. They form the physical entrapment of platelets, and activate platelets through the NET-associated histones also. And then there is a profound platelet activation lead to procoagulation. Chemotherapy used in cancer patients also cause the direct damage to the endothelial cells and cause the apoptosis, causing the thrombus formation. They also activate platelets, monocytes, and also generate the reactive oxygen species. All these mechanisms will lead to imbalance of procoagulant and anticoagulant pathways. So, along with all these common mechanisms, each cancer has certain prominent mechanism which will promote the thrombosis in that type of cancer. So, for example, lung tumors, increased GCSF production will lead to NET formations, whereas in ovarian tumors, there is increased TPO and IL-6 formation, and also in pancreatic tumors, increased tissue factors and microvesicles, whereas in brain tumor, more expression of podoplanin and microvesicles. In hematological cancers, hematological malignancies, multiple myeloma, myeloproliferative neoplasms, acute promyelocytic leukemia, other leukemias and lymphomas also promote thrombosis. And each of them have a certain prominent mechanism. For suppose in myeloma patients, 1 millibrand factor and ADAMTS axis is mainly involved in the thrombus formation, and also the immunomodulatory drugs used for the myeloma will enhance this effect. In MPN cases, JAK2, which is expressed on the stem cells, also activates the leukocytes and increased neutrophil activation and increased neutrophil production, along with excess production of RBCs and platelets. All these pro-inflammatory agents, along with the adhesion molecules on the endothelial cells and 1 millibrand factor, it will lead to the thrombus formation. In APL cases, thrombus is formed because of the same mechanism, such as tissue factor, cancer coagulant and cytokines, whereas the annexin produced on the APL cells will promote the fibrinolysis and thus DIC. So all these mechanisms in total cause the imbalance in the procoagulation and anticoagulation, increasing the thrombus formation, and this will lead to the biomarkers which are highlighted in red in this picture. And these biomarkers can be used to predict the risk of thrombus occurrence in the cancer patients along with a certain scores. And this will be discussed further by Dr. Himal.
Thank you. I'll be moving on to the risk scores in the cancer-associated VT and biomarkers. So, as we have already seen that there are so many mechanisms at play, so many risk factors at play. So, there is no single risk factor that is associated with or can predict the potential of VT in these patients. So, you usually require a group of independent risk factors which can modify this risk, and this collection is what we call a risk assessment model. So, another important point is not all cancers will require primary this thromboprophylaxis, because different cancers have different inherent risk for development of VT. Along with that, we also need to identify the risk-benefit ratio here, because these patients are also at an increased risk of bleeding. So if we start anticoagulation in patients who are not at a very high risk of thrombosis, these patients might end up bleeding more than the risk of developing VT. So the first risk assessment model that was given was by Khurana, that we all know is a very important score, which was developed and validated in 2008. And it is also given in the guidelines by the American Society of Clinical Oncology. And in 2019, they have included many solid cancers, including lymphoma. However, there is one caveat that they do not have a cohort of brain tumors and multiple myeloma patients, which are also having an increased risk of VT. So what they found was there is a significant risk of VT in patients dependent on the site of cancer. So the very high risk includes the gastric and the pancreatic tumors, as already told by Dr. Pratyusha. So when you have a very high risk, this score is given the odds ratio is more, the score is high. Along with that, there are association with platelet count, the hemoglobin level, the pre-chemotherapy leukocyte count, and the BMI. So whenever these patients had a score of more than equal to 3, that is the high risk group, these patients were at an increased risk of developing VT around 6 to 7%, which calls for starting anticoagulation in these patients. The next score was the Vienna modification of the Khurana score. So Vienna modification was developed in 2010, and this is when the Khurana score was not yet validated. So what they did was added 2 markers, that is P-selectin and D-dimer levels, and they tried to improve this prediction of the Khurana score by adding these 2. And the important point was they had included brain tumors and multiple myeloma patients in this, which is considered to be a high risk of VT. So in this again, they have found that whenever the patients had more than equal to 3 points in score, the risk was more than 10%. So again, this falls in a higher risk group, and all these patients require thromboprophylaxis. Moving on, in 2018, a modification was sought after because there was P-selectin included in the Vienna modification, which is a not a very easily accessible marker and clinically not viable to have that. So they wanted to simplify this assessment scoring. They identified one important score, that is the tumor site risk, which was very important in the Khorana score. Along with that, they found was D-dimer levels, which was also significantly associated. So a follow-up of up to 6 months was considered, which is the highest risk of these patients developing VTE. They developed a nomogram, that is a continuous scoring system rather than a single time point. So you can identify these patients even at the start of the before starting chemotherapy or any treatment modality, as well as once it is started. So instead of taking a cutoff, they have seen that those patients with a 5% or more risk of developing VT versus those who had less than 5%, there was a significant difference in developing of VT or prediction of that score. So it was considered important. There are other tumor specific scores also, as well as chemotherapy specific scores, like protect risk score, which includes those patients who are on platinum based therapy or gemcitabine chemotherapy. So both of this were given a score of 1 point, and this is those patients who are on this specific chemotherapy, we can use this particular score. The Caprini score is about the surgical oncology patients. So they have included multiple variables here: age, then the type of surgery, the orthopedic surgeries being more commonly associated with VTE, inherent risk of the inherent prothrombotic state of the patient, whether congenital or acquired, the mobility of the patient, whether prolonged immobilization is there or not, and whether the patient has any present or any previous history of malignancy. So again, here the same thing, the more than equal to 5 points was the highest risk group, and that was associated with higher risk of developing VT, and they were all selected for thromboprophylaxis. We have many tumor specific scores available. However, they require external validation, but specifically in hemat malignancies, we have MPNs and multiple myeloma, which we already have established validated scores which are in use. For example, here we have conventional 2-tiered risk stratification, where you have age more than 60 as well as previous history of thrombosis. And further on, IPSET thrombosis as well as the revised IPSET, they considered cardiovascular risk factors and JAK2 mutation. In multiple myeloma, we have IMPEDE and the SAVED score. IMPEDE score is one of the scores which is already recommended by the International Myeloma Working Group as well as the National Cancer Network. So basically, you have this score already in the recommendations. It is used, IMPEDE score is used for those patients at the start of the chemotherapy or those patients on immunomodulatory therapy, while the SAVED score is only for those patients who are already started on immunomodulator drugs like the lenalidomide. The common biomarkers that you have already seen in these, but all these risk scorings are hemoglobin, platelet, leukocyte counts, and the D-dimer levels. While the research parameter that we saw in the Vienna modification was soluble p-selectin levels. Although not validated, high levels more than 75th percentile has found to have an increased risk, almost 2.5-fold increase in the risk of developing VTE. And there are numerous other biomarkers which is not possible to cover in a single go, but includes interleukins, especially IL-6, reduced high-density lipoprotein, then the serum albumin levels, mean platelet volume, as well as the platelet lymphocyte ratio and neutrophil lymphocyte ratios. Although these are having good prediction value, everything, but we need to know that there are certain problems associated with this. One, it requires further refinement, because even the low and the intermediate risk groups have substantial risk of developing VTE. So we require further refinement of this scores. External validation, because tumor specific risk scores are available, but they require validation furthermore. And biomarkers should be easily accessible. You cannot just use any biomarkers. You need to understand that there has to be a clinical viability of that. And the bleeding risk, which is the other side of this coin of thrombosis in these patients, also needs to be taken into account. All in all, how to choose which risk models in what patients. So when the patients are already started on chemotherapy, you have Khorana and the CAT score available with you. While the patients, if they are newly diagnosed, not yet started, you have Khorana and CAT score also. Along with that, you have Vienna modification if you have p-selectin available at your institute. Oncological surgical related VT, you have Caprini score. For newly diagnosed multiple myeloma, you have IMPEDE score. And for patients on IMIDs, you have SAVED score. MPN patients, PV and ET, you have conventional risk scoring system and revised IPSET, while for cancer patients on gemcitabine or platinum-based chemotherapy, you have PROTECT score. Now, I'd like to invite Dr. Anil to take the session further.
Thank you, Dr. Hemil. Good evening. As I speak, we'll discuss the clinical profile and patterns of cancer-associated venous thromboembolism with our experience at AIIMS. So we have two large groups of data, one gathered from 2011 to 2015 and published as an original article. The other data is from 2021 to 2023, still yet unpublished. Comparing these two data, the previous study was a retrospective study in nature. The second one was prospective study. In the first study, we included only outpatient department patients, whereas in the second study, we included both OPD as well as admitted patients. The sample size was significantly higher in our 2023 study, with 139 being the total number of patients. The incidence of cancer-associated thrombosis was 8.3% in our first study, whereas which increased to around 10.6% in our second study. With respect to talking about hematological malignancies, only lymphomas were included in our first study conducted in 2015. Whereas in 2023 study, we included all the hematological malignancies, including acute leukemias as well as MPNs. There isn't any much difference in the median age of diagnosis, whereas a slight preponderance towards female sex can be seen in both of our studies. Coming to timing of VTE diagnosis, most, if not all, patients were diagnosed with VTE within 1 or after 1 year of diagnosis of cancer. However, it can be noted that the incidence of diagnosing VTE increased more than 3 times before the diagnosis of the malignancies. This was seen in our second study. Coming to the sites of primary malignancies, in our first study, gynecological malignancies were the most common primary malignancy sites, followed by genitourinary and gastrointestinal sites. Whereas in our second study, the hematological malignancies were the most common, narrowly followed by the gynecological malignancies. Talking about the VTE incidence across various stages, advanced malignancies with metastasis, that is stage 3 or stage 4 malignancies, were more commonly associated with development of venous thromboembolism. Whereas talking about the VTE across histological subtypes, adenocarcinoma contributed to more than 50% of the incidence of venous thromboembolism. While we talk about the risk factors of cancer-associated venous thromboembolism, the non-remission status or the active malignancy of the patients were seen in most of the patients who developed venous thromboembolism, that is 85%. This was followed by patients who were receiving active chemotherapy. The other common risk factors were that the patient were non-ambulatory status with immobility, or the patients who are undergoing surgery or have received radiotherapy, and the existing central lines. Talking about the sites of thrombosis, in both of our studies, lower limb remained the most common site of thrombosis. However, it can be seen that in our second study, the incidence of lower limb thrombosis reduced to almost half of the previous incidence at the cost of increased incidence of abdominal vein thrombosis and neck and thoracic vein thrombosis. The reason for this change or discrepancy could be attributed to multiple facts. One is that in our recent study, it included the admitted patients as well as patients with all hematological malignancies, which had MPNs as well as acute leukemias. The incidence of catheter-associated thrombosis was also increased, and most of the abdominal vein thrombosis, which had a triple increase in incidence, were MPN related, that is myeloproliferative neoplasm related. Just a point to note on the second most common site, that is abdominal vein thrombosis or the splanchnic vein thrombosis. Our data shows that 56% of the cases were related to MPNs, that is myeloproliferative neoplasms, and in many of these MPNs, VTE, that is thromboembolism, preceded the diagnosis of MPNs. Many of these cases were either a referral from the Department of General Medicine or gastroenterology, referred in view of abdominal vein thrombosis, and upon further evaluation, a diagnosis of MPN was established. In a study published by Barbe et al. In February 2022, they have shown that the thrombosis can be an event heralding the diagnosis of MPN in around 20% of the cases. The incidence is highest in patients with polycythemia vera, followed by essential thrombocytosis and primary myelofibrosis. In their patients numbering around 241 with splanchnic vein thrombosis, they show that the association of JAK2 mutation was found in 45% patients of Budd carrier syndrome and 34% of patients with portal vein thrombosis. We also, in another study published by the Department of Hematology in 2018, explored the association of JAK2 mutation in non-CML MPNs. Among the 36 patients who developed the thrombosis, The most common site was a splanchnic vein thrombosis with 72%. Also, coming to the association of JAK2 mutation, 32 patients had JAK2 mutation present, among which 20 patients, around 62.5%, developed thrombosis, whereas 12 did not. Now I call upon Dr. Swapnil Tripathi to discuss the management of cancer-associated thrombosis.
Good afternoon, everyone. Thank you, Dr. Anirudh. I'll be talking about the management of cancer-associated thrombosis. So I'll be covering three topics. First is prophylaxis. Second is treatment of the initial episode, and the third is practical challenges. So not as already told by Dr. Hemil, not all patients of not all patients of malignancy needs prophylaxis. The indications of prophylaxis are patients with active malignancy requiring hospitalization due to any cause, patients undergoing major surgeries, patient with high risk of thromboembolism calculated by Khurana score of more than 2, and patients with myeloproliferative neoplasm or multiple myeloma receiving immunomodulatory therapies. So what agents to choose and till what time you need to give a prophylaxis is as follows. Patients who are undergoing surgery, the anticoagulation should be started 2 to 4 hours in the preoperative period. It should be continued for a minimum of 7 to 10 days. In patients who are undergoing abdominal or pelvic surgeries, it is advisable to give an extended therapy of anticoagulant for a total of 28 days. And low molecular weight heparin is a preferred anticoagulant of choice as compared to unfractionated heparin because of OD dosing. Next is medically treated patients. All patients of malignancies like pancreatic cancers, multiple myeloma, or myeloproliferative neoplasm requires prophylaxis anticoagulation or antiplatelets, as in case of myeloproliferative neoplasms. Then what factors are important to consider before choosing an agent is, many of the patients of malignancies may have organ dysfunction. So considering renal dysfunction and creatinine clearance, hepatic diseases, elevated transaminases and bilirubins, and also the bleeding stress assessment of the patient. Logistic include whether the patient is an admitted patient or OPD patient, the cost of the anticoagulant which has been given, and the patient's preference. Services related include monitoring of the patients, along with that ability to reverse anticoagulation in need of emergency surgery. Now coming to contraindication to prophylaxis. So the contraindication to pharmacological anticoagulants include active bleeding, platelet count of less than 50,000, underlying hemorrhagic tendencies, patients requiring either a lumbar puncture or a neuroaxial catheter, or patient with a prior history of heparin-induced thrombocytopenia. Contraindication to mechanical prophylaxis, which can be added to patients with patient on pharmacological prophylaxis, includes acute DVT and severe arterial insufficiency. The above two are an absolute contraindication for doing a mechanical prophylaxis. Large hematoma or skin ulceration are the other contraindications. Now coming to the treatment, patients with venous thromboembolism in malignancies require an initial therapy, which is for a period of 7 to 10 days, followed by a prolonged therapy. The agent of choice for initial therapy is either a low molecular weight heparin or a oral factor 10 inhibitors. Mainly, apixaban and rivaroxaban are the only agent which are being recommended in patients for the initial therapy. The newer anticoagulants need to be avoided in patients suffering from GI or genitourinary cancers due to increased risk of bleeding seen in the trials. Then once you have given an initial therapy of 7 to 10 days, patient are to be given total anticoagulant duration of 3 to 6 months. And in patients who have an active cancer, even after 6 months, need prolonged anticoagulant therapies. Now, out of the different anticoagulants available to us, this is a table comparing the two studies which are done at our centers, comparing what anticoagulant were used. In the 2015 study, the most common anticoagulant which was used was heparin followed by vitamin K antagonist. But in the recent study, DOAC or newer anticoagulant has been used the most common, followed by LMWH, because of easy availability and also cost affordability of the patient. Now, duration of therapy, as I've already told, the total duration of therapy is a minimum of 3 to 6 months, but patients who have active disease will require a longer term, that is more than 6 months of anticoagulation over a short term therapy. And you can see that most of the patients at our center who have a malignancy has been given a total duration of therapy of more than 6 months, as seen in around 75% of the cases. Now, coming to hematological malignancies, the three common hematological malignancies are myeloproliferative neoplasm, multiple myeloma, and acute leukemias. So, for myeloproliferative neoplasms, the primary prophylaxis include phlebotomy to maintain a hematocrit of less than 45%, low dose aspirin, as it was seen in the ECLIPSE study, and a cytoreductive agent to be given in patients with high risk of disease, that is age more than 60 years and a history of prior VTE. The treatment include either a DOAC or vitamin K antagonist and adding a cytoreductive therapy in the secondary prophylaxis. Next is multiple myeloma. Based on the various scoring systems, newer anticoagulants are preferred over aspirin if the patient has high risk of thrombosis. Aspirin may only be used in patients with low risk score, as the various scores are impaired and safe. In acute promyelocytic leukemia, although acute promyelocytic leukemia is a disorder where bleeding is more common than thrombosis, around 10% of the patient develop thrombosis. And although there is no role of prophylaxis in acute promyelocytic leukemia, anticoagulant may be needed for life-threatening thrombotic event with taking care of the platelet count of the patients. Now, coming to practical challenges, a lot of patients presented to us we find difficulty in starting anticoagulation or a treatment interruption. The common causes of treatment delay includes bleeding, active bleeding, thrombocytopenia, bleeding secondary to thrombocytopenias. This is in the recent study, out of total 139 patients, we were not able to start anticoagulant in a total of 15 patients, with bleeding and thrombocytopenia being the most common cause. The treatment interruption is another thing that needs to be taken care, and the most common cause of treatment interruption is bleeding followed by thrombocytopenia. So, patients on anticoagulants may have bleeding from multiple sites, including the most common being skin, menorrhagia, and GI source. This is the chart comparing the patients on DOAC, heparin, and vitamin K antagonist. As the recent study showed, most of the patients were on DOAC. Out of the total 67 patients, around 20%, that is 12 patients, developed bleeding, but a total of around 8 patients had bleeding that lead to treatment interruption. And the patient receiving vitamin K antagonist are nearly 3 out of 3. The 100% of the patient who had bleeding required a treatment interruption. Now, the management of thrombocytopenia in patients who have an acute VTE. So, if the patient is an acute VTE, that is a venous thromboembolism in less than 1 month of duration, you need to give anticoagulation at full dose if the platelet count is more than 50,000. And if the platelet count is less than 50,000, you may need to transfuse the patient to maintain a platelet count of more than 50,000 along with full dose of anticoagulation. Whereas in patient who has a older VTE of more than 4 weeks and platelet count is more than 50,000, you need to give full dose. If the platelet is between 25,000 to 50,000, you need to reduce the dose by 50%. And if platelet counts drop to less than 25%, you need to stop the anticoagulation because of increased risk of bleeding. So, if a patient of malignancy on VT therapy requires an intervention, what to do? So, if the patient needs an emergency surgery, the protocol is to give a reversal agent followed by surgery. And what to choose in a post-operative period and when to start depends on bleeding and thromboembolism risk. And if the patient has high risk of bleeding because of anticoagulation, you may consider an IVC filter, which is a retrievable filter is preferred over a non-retrievable one. So, this is the list of reversal agents which are available. Out of this, the protamine, which is a reversal agent for heparin and low molecular weight heparin, is easily available. The reversal agent of direct oral anticoagulant is adenoxylate alpha, and idarosumab is not easily available in our country, whereas reversal agent for warfarin, which is vitamin K and FFP and PCCs, are easily available. So now we'll be discussing on complication and quality of life by Dr. Rachit.
Good afternoon to one and all present here. I'll be talking about the complications and quality of life in patients of cancer-associated thrombosis. To begin with, the most common complications seen in this group of patients is recurrent venous thromboembolism, bleeding, post-thrombotic syndrome, and chronic thromboembolic pulmonary hypertension. To begin with, cancer-associated thrombosis, it presents a unique challenge because it is associated with an increased risk of both recurrent VTE as well as bleeding. So managing anticoagulation may be tricky. The risk factors associated with recurrent VTE are presence of an adenocarcinoma subtype, metastatic cancer, a performance status worse than 1, presence of pancreatic or hepatobiliary cancers. The cumulative incidence of recurrent VTE has been estimated to be around 6.8% and 20.7% in patients without cancer and with cancer. Regarding the management of recurrent VTE in these patients, there is lack of robust data as to what needs to be done. However, the usual strategy that is adopted is includes a change in the agent. Like suppose if the patient is on LMWH, we may prefer to change him to DOAX, or we may consider increasing the dose by around 20 to 25%. Regarding the next complication, bleeding, the risk factors associated with this particular complication includes the presence of an upper GI cancer, genitourinary cancer, a performance status worse than 2, and the presence of metastatic cancer. The cumulative incidence of bleeding is estimated to be around 4.9% and 12.4% in patients without cancer and with cancer. Conventionally, for the management of cancer-associated thrombosis, LMWH or low molecular weight heparins have been considered to be the standard of care. However, multiple randomized control trials have been done, and it kind of shatters our old belief that DOACs are not a good agent for the management of this subset of patients. The three RCTs are Hokusai VTE cancer study, SELECT-D study, and Caravaggio study. The meta-analysis of these randomized control trials has suggested that there is no significant difference in the incidence of recurrent venous thromboembolism or major bleeding between the two groups. However, a catch point is the SELECT-D study has suggested that there is higher incidence of clinically relevant non-major bleeding in patients of rivaroxaban arm. Moving on to the next complication, that is chronic thromboembolic pulmonary hypertension. Its incidence is estimated to be around 0.1 to 9.1% in VTE patients. However, data regarding its exact incidence in cancer patients is scarce. Some of the studies have suggested a figure of around 0.75%. Recurrent VTE has been considered conventionally to be a risk factor for chronic thromboembolic pulmonary hypertension. And since cancer patients are at a higher risk of recurrent VTE, we can expect chronic thromboembolic pulmonary hypertension to be more prevalent in this group. And occurrence of this complication is associated with a shorter survival. Post-thrombotic syndrome, the incidence of this particular complication has been estimated to be around 30 to 50% overall. And it is a significant contributor to poor quality of life. And as I previously mentioned that cancer patients are at a higher risk of recurrent VTE, they may probably be even at a higher risk of post-thrombotic syndrome. And recurrent VTE is a risk factor for post-thrombotic syndrome, and post-thrombotic syndrome is a risk factor for recurrent VTE. Next, I'll be talking about the quality of life of patients of cancer-associated thrombosis. Different scoring systems can be used. That is the FACT-G questionnaire, the medical outcome study, that is MOS, European Organization for Research and Treatment of Cancer, that is EORTC, venous insufficiency study, that is VEINS. In our study done, we have used the FACT-G questionnaire. It consists of 27 questions and 4 domains. This questionnaire takes around 5 to 10 minutes to be administered, and the response of the patient is graded as 0 for not at all to 4 for very much. And this is a Quavitac study. It was a prospective study which has studied around 400 patients of cancer-associated thrombosis, and their quality of life at baseline at 3 months and 6 months has been assessed. And based on the MOS and the EORTC questionnaires, there was an improvement in the quality of life. And this improvement in quality of life correlated with a poor performance status at baseline and the presence of symptomatic venous thromboembolism. Regarding the R-center experience, as we can see from the line diagram, and there was statistically significant difference in the quality of life at baseline and at 6 months in all the domains except for social well-being scores. The next important observation in the study was that when different anticoagulants were used in this group of patients, there was no significant difference in the quality of life. And this is once again a chart showing the relation of quality of life to different factors. as we can see and as we expect, as the performance status is better, the quality of life is better, and quality of life tends to be better when the cancer is under remission, and it tends to be worse when the cancer is relapsed. Now I'd like to call upon Dr. Mukul Agarwal sir to carry forward the session.
Good afternoon, everyone. So the future of cancer-related DVT research lies in having more better risk stratification scores to see what patients will be needing prophylaxis and maybe developing better agents for this prevention as well as treatment. What do we have in this regard? So artificial intelligence is making inroads into everything, including risk stratification scores. This is an interesting study published a couple of years back, in which they use various machine learning methods to predict cancer-related DVT in using various clinical variables. Various machine learning methods were utilized. Overall incidence of cancer-related thrombosis was around 22%, and the predictors came out to be the usual ones: D-dimer, age, performance status, length of stay, and previous thrombosis history. Of the various machine learning methods, two methods stand apart. These were linear discriminant analysis and logistic regression, and their combination with D-dimer showed better performance over the traditional used Khorana model. So this is something interesting and can be used subsequently. 2021 showed these two molecules, which are inhibitors of factor 11, one oral milvexian and IV abelacimab, to be used for prevention of thrombosis in knee replacement patients. So these agents and their congeners have now been tried in other settings as well, including stroke and myocardial infarction, and there is no reason to believe that these agents will not be tried in prevention of cancer-associated thrombosis. Summarize, I'd like to highlight that CADVT is a very important cause of mortality as well as morbidity, the incidence of which is rising, and newer risk factors, including certain therapies, is emerging. We need to be aware of certain therapies which can be associated with increased risk of thrombosis. Simultaneously, there are various risk prediction models can be used for prophylaxis of patients. Of the various risk prediction models, Khorana score has stood the test of time and is the most commonly used model for this. Newer anticoagulants and LMWH have been the agents of choice for prophylaxis and treatment. DOACs are preferred for almost all the cancers, albeit GI and GU cancers, in which the risk of bleeding is slightly higher, where conventional enoxaparin or LMWH are slightly preferred. As we saw from our department thesis in the prophylaxis in the prospective data, we see that there are major real-life issues which occur in these patients, especially rebleeding, especially stoppage of anticoagulation during thrombocytopenic episodes, and certain other complications which need more data to be and quality of life improves with therapy for both CA and DVT. Future lies in exploring newer agents and risk reduction models for with AI and ML. Thank you, and I invite comments and questions. Thank you.